Vanessa, I think this is everyone who's going to be here, and we actually have 6 people, so we're good. So if you want to go ahead.
Who's the other person? I don't see anybody else.
LaDawn will not be here this morning.
Okay.
Maria obviously is out, and Mulan is not here.
So I'm going to call this meeting to order. Let's take a moment of silence for those infected and affected with HIV. Let's take a couple of minutes to introduce ourselves. Anybody want to start?
Julian Vega, Housing Program Manager. Good morning.
Good morning.
Maylan Peguero, Intensive Housing Case Management Program Manager.
Good morning, Brian Duback, Senior Prevention Program Manager.
Good morning, Angus Bradshaw, Executive Director and QM Champion.
Good morning, Kelly Bastian, Part A office here in a listen-only mode.
Wyatt Haro, Quality Management and Recorder.
And Vanessa Rivera, Intensive Case Manager, Program Manager, Chair. Welcome, everybody. Megan?
Okay, just a reminder to everyone to not talk over one another. If you need to speak or if you have a question, please raise your hand either on the screen or at the bottom of the Zoom meeting. You can raise your hand as well and wait to be called on. Thank you, Wyatt. Thank you. Let's have a successful meeting today.
Good morning, everybody. I make a motion for us to review and approve today's agenda. It is corrected on the screen, so it does say we called order at 9 a.m., not 1 p.m.
So I want to, Wyatt, do you put the half measures on the screen?
Yep, they'll be up there.
Okay, thank you.
Everything's ready.
We're going to start with which one, the referral specialist or the MCM?
First, I make a motion for us to approve the agenda.
Oh, okay.
Does everybody approve today's agenda? Let's do a roll call. Julian,
Yes.
Vanessa,
Yes.
Brian,
Yes.
and Angus. I think he got up for a moment. I move forward with the agenda as well. Angus, do you approve the agenda? Okay, thank you.
And of course, I approve it. I wrote it. All right, so let me switch screens here so you can see the half measures. If you moved any slower. So the first one is the referral specialist.
So yes. So we are looking at the half measures in the two different components of the Ryan White case management. We're going to first look at the referral specialist. So why is it important that we look at the half measures? The half measures are kind of like our report card. How well are we doing meeting HRSA's guidelines? And what needs to improve to ensure that we do meet the targets. So as we're looking at viral suppression, we see that we're at 84% and we should be at 93%. And looking also at how many people we serve and how many people are virally suppressed. So one of the things that we really want to focus on moving forward is actually ensuring that all of our medical appointments are enter and provide. So if we look at the HIV medical visit frequency, we are at 39%. And we should really be at 90%, which means that all of the appointments are not being entered on a continuous basis. So as we touch the files and we see the alerts, we should be inquiring from the client or making phone calls to the providers, inquiring about clients' appointments so we can update that appointment tab. That's very important and provide. The annual retention in care should be at least at 70%, and right now we're at 58%. The gap will improve as the appointments are entered and retention improves. So it's like a domino effect. We're supposed to be at 10% or less. So it's important that we continue to work towards these targets by doing different things, whether it be getting the information directly from the client, getting the information from the providers and putting them in the appropriate tabs, not just in the case notes. Does anybody have any questions regarding the percentage that we're showing right now before we move over to the medical? Any
I do.
questions regarding?
One question, Vanessa, and we're only documenting their AOMC appointment, correct? Nothing besides that is what's counting in this category.
That's correct. We should always put every appointment we have with the client. So we're doing a face-to-face or whatever, we should enter them and provide. However, what is considered meeting the half measures is the appointments that the clients have with the providers.
Okay.
That is what we're looking at. That's how we can identify if retention and care has been met and viral suppression is being met.
Are we seeing any increase from your last run on these HAB measures?
So from looking back in August, we have had some improvement.
Okay.
Because we were like at 43% when it came to medical visit frequency, and now we went down a couple of percentage, like 4%. So we're now at 39. So there has been some improvement. And remember that this is also measuring an entire year. So this is looking at October 1st, 2021 through September 30th, 2022.
Okay.
So a lot of these clients may no longer be with us, but they're still counted.
Okay.
So we should continuously see improvement on a monthly basis if we're entering the appointment in the appointment time.
Okay. Thank you.
You're welcome. Let's look at the medical case management one. So,
Real quick, Vanessa, before you go on. So just so that there's a reference point. So this one was run on to run October 1 of last year to September 30th. But
Mhm.
for the entire year of 2021, for referral specialists, annual retention and care was at 65%, so it has decreased. Medical frequency was at 49%, so that has increased. And gap was at 31, so that's increased. And then in 2020, it was a 74% for annual retention and care. Gap was 16, and medical visit frequency was 65.
So as clients are returning back to face-to-face appointments, we should be seeing improvement. We did have a time there during COVID time that could have affected our half measures, most likely, because a lot of clients weren't keeping appointments because they were either telehealth, clients didn't know how to function their smartphones, were too afraid to come out, didn't schedule anything, didn't get labs done. So all of those things could have affected, but as we're moving back to more face-to-face medical appointments, we should see some improvement. So the medical case management half measures, we're at 83%, and we are supposed to be at 92. Appointment frequency, we are at 39%. We should be at 90. And the gap, we should be at 10, and we're at 33%. And then retention, annual retention, we're at 59, and we're supposed to be at 65% for October 1st, 2021 to September 30, 2022. So as a group, what we all should be encouraging our staff to do is ensuring that when they speak to the client, they find out the appointments, that we're going to that appointment time, not just adding it to the case note, but also to the appointment tab, because that's where all this information is being pulled out of. It doesn't go into the progress notes to pull the information. So the information is extracted from the tab, the appointment tab. Why
Yes,
do we?
I'll be sure to add that to the referral specialists meeting, because we just met last week and I didn't mention this at all about adding it to the tab. So in the next meeting I do with them, I'll make sure they're adding it to that tab. And I haven't been looking at it when I'm going through their files to do stuff with them. I have been paying attention to that, so I will do that moving forward.
Yeah, that's even, even housing. Let's say a client is in housing and also have a referral specialist. If the housing case manager knows that the client's been to the appointment, they can go in there and add it too. It doesn't necessarily has to be just the referral specialist or just the medical case manager. As we know this information and we can confirm the information is correct, we could enter the information and provide. We all have access to provide, and we could all complete this entry.
So Vanessa, so we're basically looking at the root cause for these percentages is simply they're not entering them into the computer, or is it that there are clients who aren't actually going to the doctor?
So it could be a variety of reasons. Could be that a lot of clients, if they're referred to intensive case management, most likely they're not virally suppressed. So probably they're not going to the doctor's appointment. So this could also affect the half measures. A lot of times it could also be that, especially those clients that go to providers outside of our EMA, that we pay more attention to those clients also because we have to call external providers, such as Bliss Healthcare, such as OIC, such as Orlando Health, other places, and we need to get this information entered. You know, if they go to the health department, sometimes the health department will enter it. If they go to CAN, sometimes they will enter it. And, you know, we don't really have to focus too much on that, even though we should still look to see that an entry has been made. It should always be our responsibility to ensure that appointments are being documented.
So if they go to a provider that's within the,
Our EMA,
Brian White.
sometimes they do enter it and other times they do not.
Yeah.
So we should still be looking at the appointment tab, especially if a client tells you, I just came upstairs to say hi because I was at the doctor's office in Cannes, let's say, for example. So we should go to that profile and say, okay, let's see if the appointment has been added. And if it hasn't, we need to add it. That's the only way that we are going to be able to improve. Information enter is what information we get out of it. So as more diligent we are with entering information, the better our half measures will look.
there's a side by side. Sorry, I was just trying to make it so you can actually see both at the same time.
Mhm.
So here, they're almost identical in percentage. The only difference, of course, is the actual denominator and numerator, but they're very, very similar in percentage. And I know that when Vanessa and I were talking about it over the last couple of days, we had discussed that if the appointments are being entered by ICMs, it'll automatically help improve referral specialists and vice versa, because it's obviously going to carry on both people's reports, depending, most clients or any client that has an ICM has a referral specialist. So that's going to guarantee an improvement on referral specialist side, but referral specialists entering will also help improve ICM that way. So it's kind of like
why it comes back. So client is touched by several parties of our agency, such as referral specialists, intensive case management, and they're also with our housing program. Those are 3 different departments that are touching this client. So we should all be focusing on their appointments and entering them, because it would definitely improve our QM. And also we will be able to understand if there are any barriers to care. And if they are, what are they? We could identify them and assist the client with eliminating those barriers. So by every person taking an active role in inquiring about medical appointments, are you taking your medication? Are you taking it consistently, correctly? Those will all be helpful in the long run across the board. So anytime that an intensive case manager that shares a client with the referral specialist enters an appointment is going to also boost the half measures for the RS. So therefore, if we all work together as a team, we can all reach the targets. It doesn't necessarily mean that we say, okay, so we're not the case management department, so we don't really have to enter appointment, but if you know it, enter it, because it would help the entire agency. This is actually how we are looked at when it comes to how we're performing as a group. Why you back?
Okay. Just a side note too, and Vanessa, Brian, since you're going to be supervising Lester with EIS, we were trained to use the tab on Friday with Kimberly. So he now knows. So even with EIS touching it, along with HOPWA, along with the ICMs, and along with their referral specialists, we now have 4 touches to the client, and especially with EIS, because their linkage happens. They can close them out and transfer them over once that linkage happens. So he should be documenting that AOMC visit in that tab when he links them over to referral specialists. And that will severely, like vastly help these numbers increase, especially that first medical appointment. So when we're reviewing his files for, QAing his files, Brian, we make sure we look at make sure he's entering in that tab, AOMC visit, when he links them to the medical provider.
Correct, because the EIS worker is going to probably get all the newly diagnosed people who fall out of care that we're trying to get them back into care. And they really are supposed to stay with the client until the client makes that first appointment visit. So they would definitely be able to enter that first appointment after engaging them back in care.
I also just wanted to put like a side note, so like everybody here knows I'm a data geek. And I always try to point out to everybody that the data is only as good, the reports are only as good as the data that's put in. So
Right.
this may not represent a realistic, real world, like what the clients are actually going to the doctors and stuff, because it hasn't been necessarily entered. But I always point out that the people who do our reviews to determine our contracts and stuff, they don't necessarily get to go out and interview every client to make sure that the report matches the client. They see the report. So we have to always make sure that the data is.
He was
We
better
lost
than-
Yeah.
He freezes all the
You
time.
keep freezing, Wyatt, yeah.
Yeah.
I don't know if he knows he's freezing though.
Wyatt, you keep freezing, so we don't hear what you said.
That's okay. You don't want to hear me anyway.
I didn't say that.
No, I think I have, because I'm doing the recording on the computer and I've got all the other stuff running. So I'm trying to close some stuff down. But basically garbage in, garbage out is what I was basically saying in terms of data. The reports are what determines our contracts, that determines our funding. And if the data is not there or the data is incorrect, well, we just are gonna suffer for it. So I'm a data geek.
Also, when a client is no longer with our agency and we don't close that client out appropriately, it continues to generate information. So let's say our client's no longer receiving case management service with the agency and we don't close it properly, that it keeps pulling that client's information, whether it be eligibility not completed, no viral or no CD4, no appointments kept. It continues to pull that information and that will reduce our half measures. It would impact what we're trying to accomplish. So once a client is no longer in any of our programs, we should immediately become very mindful in closing them out. That way they don't continue to run in our QM reports.
I was gonna say on top of that.
Especially when a client is only getting one type of service. Remember that all this information is being pulled from our main database. And it does affect us across the board.
So Vanessa, what you're saying is that if you see that the client is only open, for example, with your program under Miracle of Love, and you're closing that client to make sure that the relationship tab all the way at the top is closed also with MOL.
Correct.
Okay.
In order for a client to be properly closed, they must be closed first in the service category and then in the main database, which is the top. So that that person will not continue to be counted towards our half measures. Because if they're left opened, and it has happened, and we really catch it like closer to RSR time, and then we start closing everything, but it's already been 5, 6, 7 months that that client should have been closed, we can't go back and fix that. That's just it. So that's why it's important that when we close these tabs, we're closing them in not only just the service category, also in the main database, so that that client is no longer being counted as working with Miracle of Love.
That, and I'll just point out really quick before I freeze again, but if we're getting flagged for it, the agency who's actually providing them services is also being flagged. So really doubling up. And so like when the grantee is looking at like the overall picture, there's 2 agencies being penalized for 1 client, even though the reality is that client's supposed to be getting services over here. So it's showing on that agency and our agency. So we got to make sure we get those closed as well. Because I know that these numbers are definitely not reflective of what the actual real world is for our clients.
Brian,
Yes.
you were gonna say something or no?
Well, I kind of had a question and I don't know if this is the place. So is there any type of reporting that's run that shows that they're closed out of the service category, but not out of the agency?
Yeah, I do that in the QM report, because what happens is it'll say, give us a flag, but it won't tell me that there's a case manager assigned to it. So when I'm putting all the stuff together, I'll see that there's a person who has like eligibility expired, but has no case manager. And so I can easily determine that that's a person who's been close with the case manager, but not the agency. So I do send that out in the QM report, and the QM report goes out every 2 weeks, starting next Monday.
All right.
So,
Gotcha.
so Brian, I would, because you'll be supervising Lester, what would be essential for you to keep an eye on would be those clients that he did eligibility for to re-engage him back in care. And now those clients are telling Lester, I want to be referred, let's say, to Hope and Health or CMWP
Okay.
or AHF, that he closes out all the tabs so that that client is no longer, client's information is no longer affecting MOL. Now that client's totally closed, transferred to another agency. So his service category should be closed and the main database should be closed.
Yeah, I'm just, the reason I'm asking, because this is all new to me, so I just want to figure out how I can best help the agency overall. And
Yeah,
if there's ways that Lester and I are going to impact it in a positive manner, I just want to make sure that we
Yeah.
get there. So,
and if
all
they
right.
stay with MOL, let's say, for example, and he's completed a referral, like for intensive case management or referral services, that if that client is not picked up within 2 weeks, that he reaches out to one of the supervisors or let you know, so that we can ensure that that client gets picked up and he can close the service category.
Gotcha.
And Brian, since I do send a QM report to EIS person, I'll also give you like a master copy. So you'll have it, I'll upload it in the portal for you as well, like I do for all the other managers. Once I
Thank you.
compile all of it, and then you'll have it so you can see exactly what I'm sending to your staff.
Perfect.
Any other questions regarding how we can work on these QM reports? We get them all the time. We just need to make sure that when we speak to our staff about QM, and I know we always say they have the afternoons on Fridays to work on it, but it should be an everyday activity. They should have it open, because every day they're touching a file. So why don't you just handle who you're taking care of as a client, and also making sure that that client is not in your QM. And if they are, that you're updating that information appropriately, improvise, so that you could document it also in your QM. And next time around, when it's uploaded again by Wyatt, that information is removed, and you'll see that as it gets shorter, is also going to demonstrate in our performance measure that we're improving. Because less information that Wyatt has to send everybody, it should show improvement in our half measures.
I just put this part up on the screen because I know that the topic was that we wanted to make sure we touched on the half measures that we're monitoring in our QM plan. And it looked, just for purposes of discussion, we're monitoring viral suppression and annual retention for both of the categories. I did update the percentages because I did not realize until yesterday that the targets for the retention part were actually copies of viral suppression, so they were really high. But Vanessa gave me the correct numbers, so I updated that. And the other part I will point out, the EIS monitoring froze.
Yeah, it's freezing again.
Yeah, I saw.
We missed we missed some information, Wyatt, that
Okay.
you were given to us. Can you go back a little bit?
I probably should have rebooted my computer, I'm sorry.
Uh-huh.
So I updated this information so that it's the correct numbers here. And Angus is still working on getting the official process for monitoring this for EIS.
Since we have Kelly on here, maybe I can call on Kelly while Wyatt reboots, come on. Kelly, what is EIS or Part A measuring for QM?
So for QM and EIS or Part A, it's different every year. But they did just go through the last planning cycle for them and monitoring that linkage to care within 30 days. So that medical appointment and then case management within 180 days. And kind of how they based everything was on the EIS episode of care is where they pulled a lot of the data from. And that's something that, at least on the Part A side, is required. And with that, you're able to clearly note, hey, when was the first kept medical appointment? And the supervisor, what they ended up doing is, of course, there's a report and provide that you can pull, hey, what's the summary of the EIS episodes of care? So you can see how many clients have you served? When were they opened? Are they still open? And then when was that kept medical appointment? So you can begin to build kind of those metrics out. So I can share